Well, thank you very much, Jim, and welcome to the NKF virtual patient event till 1:40 this afternoon. As Jim said, we've got a packed programme today. If you'd like to ask any of the presenters any questions, all you have to do is type them into the chat box on the right hand of your screen. Now, we're going to be looking today at the dialysis decision making, hear from the couple of patients with their transplant stories, a fascinating look at the Renal Services Transformation Programme, hear from two lovely ladies who are on dialysis, talk about COVID, how could we forget about that? And we're going to kick off with Professor Simon Davies and David Coyle regarding the BISTRO study.
Good morning, everybody. My name's Simon Davies. I'm a clinical researcher and nephrologist based at Keele University and the University Hospital of North Staffordshire, and I'm chief investigator of the BISTRO trial. David, do you want to introduce yourself? Although I'm sure people know you.
Hi, everybody. I'm David Coyle, and many of you will know me as a member of the NKF executive. But today I'm wearing my other hat as a patient co-investigator in research.
Thanks, David. So I think if we, Pete, can we move to the slides and I'll explain how this will work. Thank you very much. So first of all, I'd like to sort of really express my deep gratitude to the NKF for giving me the opportunity to tell you about the BISTRO trial. I'm a great believer that research should be properly disseminated to patients, but especially when patients have been such a large part of a study and how it works, and hopefully it'll have some useful outcomes for them. So the BISTRO trial, what I'm going to do is present the main data, and then obviously we'll take questions at the end, but also David will, I think, say some words after I've finished about the involvement of patients in both the design, the delivery and the dissemination of this trial as part of our Q&A at the end of the session. So the first question I wanted to address is, why did we do the BISTRO trial? What's it about? So as many of you will know, that when you start dialysis, it's usual that you've still got a little bit of kidney function left. And we know from observational studies that if that is the case, then the longer that kidney function that you have of your own lasts, then generally that has benefits for patients on dialysis. They generally feel better, they have a better quality of life, and indeed they probably will actually have better survival on dialysis. So we know this is a really, really important part of what we should be trying to preserve in hemodialysis patients. But surprisingly, there's actually been very few trials or studies that really address this problem. We also know that when you're on hemodialysis, when they're removing fluid on the dialysis, which we all know has to happen to compensate for loss of kidney function, but if that fluid removal is quite aggressive and it causes dehydration during the course of a hemodialysis session, that can switch off that remaining kidney function. So what we wanted to do in the BISTRO trial was to see whether, if we used a standard pro forma that encourages people to approach the setting of the target weight, which is how we manage this problem on dialysis, if we could have a process of setting that which was standardized, could this preserve residual kidney function longer? And in particular, we wanted to know whether using a Bio-Impedance device, which is an electronic measurement that is taken from the patient's body to try and measure the amount of fluid in the body, could that help improve the preservation of residual kidney function over time? So this is that structured pro forma that I was talking about. You won't be able to read all the detail on this slide, but it just shows you on a single side of A4 that we encourage clinicians, or we ask clinicians, to use this as a pro forma to help them think about setting the target weight correctly. It has on it some important information on the left-hand up corner, like current weight, the blood pressure, and on the right-hand side, a series of questions or comments are asked for the clinicians to think about, that might affect how you might set that weight. It thinks about physical examination, about the likelihood that the patient is putting on or gaining or losing weight, whether or not the patient has extra fluid gains on dialysis, between dialysis sessions. Obviously, things about blood pressure. And importantly, and you won't be able to see this, but it also takes the patient's preferences into account. So it actually asks whether the patient felt better with a lower or a higher weight on dialysis. And I'll come back to that towards the end of my talk, because I think it's really important. So this was the pro forma that they used. And of course, they were asked to make these measurements on a standard way. So initially every month after starting dialysis, and then once things were settled down, every 3 months for the next 2 years of follow-up in the study. So just to say a little bit about the conduct of the studies, you can see here from this slide that this was a UK-wide study. It involved 34 centres across the United Kingdom, all of the provinces. And we recruited a total of 439 patients to the trial. You can see on the right hand of this slide that we started recruiting in about April 2017. We finished that recruitment process in October 2019, and the trial finished completely once everyone had 2 years of follow-up at the end of September 2021, in other words, last year. So this is the main outcome of the trial I'm going to show you on this slide, and it's important for me to explain to you that it's when you're doing a trial of this sort, really big trial with a lot of money being spent, what you have to do before you do the trial is make predictions. You have to say, well, we think this will happen, and then you're testing against that what actually happens when you do the trial. And we looked at a lot of papers that are written about residual kidney function in hemodialysis patients, and we estimated from those studies that we expected by about 1 year that about 25 to 30% of people will have lost their kidney function. And from that, we predicted that in a trial of this size, we would see about 185 people lose their kidney function over the 2 years of follow-up in the study. What we actually found when we did the trial, however, was that only 72 people lost their kidney function during that 2-year follow-up. In other words, that was much less likely to happen than we were expecting. And you can see here in the lower part of this graph, these two lines, the turquoise and the red line, you can see the two limbs of the trial, which were the patients who had the bio-impedance shown in the red, and the patients who did not have the bio-impedance shown in the pink, in the turquoise. Remember, all the patients were using the pro forma. And you can see that bio-impedance was a bit better. If you added bio-impedance in, it looks better on that graph. It's a slightly lower rate, but actually by 2 years, there was no difference between the two groups. So the bio-impedance itself did not seem to add to this pro forma in terms of improving the rate of loss of kidney function, but that was much less rapid than we were expecting. Now, we also measured a lot of other things in this trial, what we call patient-reported outcomes, in other words, things that are really relevant to patients in terms of how they live and feel, which were very important to measure. And this, I've just chosen one of these because there's a whole bunch to show, but I've only chosen one, which is the dialysis recovery time, because this actually turns out to be really important. It really predicts how well people do on dialysis treatment. And you can see on this, so if you look at this sort of coloured bars here, you can see the two extremes at the end. So the pink at the top of these bars are people who get better from a dialysis session within minutes. And at the bottom of that column, you can see in the purple colour, people who literally don't feel better after a dialysis session until just before they start the next dialysis session. In other words, 2 days later. And you can see there's a wide range of that. With varying recovery times reported. And over the course of the 2 years, you can see that there's a very slight drift, slightly fewer people in the top pink bars, perhaps a few more people in the blue bars, which were feeling better by the next morning. but there's no difference between the two groups. So if you had whether you used the Bio-Impedance or just the pro forma on its own, there was no difference between those. And I can tell you from comparing this to other studies that actually this is still quite good. This lack of change over time is relatively slow in this patient cohort. So one of the questions we wanted to ask was, why did the Bio-Impedance not improve things? Why didn't it make it better? And the answer to that is, it turned out when we did an analysis after the event that actually the doctors and nurses setting the target weight were doing just as good a job as whether they had the Bio-Impedance or not. In fact, they were doing a very good job. On average, there was no difference between the target weight set by the doctors and that measured by the Bio-Impedance device. In fact, the doctors and nurses were doing exactly what we asked them to do, which is to stop patients from getting dehydrated at the end of a dialysis session. Of course, there was some variation in that, but on average, they did. There was no evidence of average dehydration at the end of a dialysis session. We also observed that when they increased or decreased the weight, that actually that was done in the two limbs of the study in just the same way, whether or not they had the Bio-Impedance or not. Now, you'll also remember that I mentioned earlier that we asked them to document what the patient's preference was. And I'm pleased to report that in the vast majority of cases, actually the fluid assessments made by the doctors and the nurses seem to be very much in agreement with the comments made by the patients, or the preferences made by the patients. To try and illustrate this to you, I've got a slightly complicated table here, but I just want you to focus on a couple of figures. So, for example, in this study, I think there was something like 3,000 or more than 3,000 fluid assessments made. And when the doctors or nurses wanted to increase the target weight, only 1.4% of the patients disagreed with that. They wanted to be at a lower target weight. And likewise, if they wanted to decrease the target weight, just 2% of those fluid assessments were associated with patients thinking the opposite. The vast majority of cases where it was measured, patients did seem to be happy with the changes that were being suggested by their clinicians. So I think that's really important. So I'm now going to just summarize my thoughts about the trial before we open it up to discussion. First of all, our main conclusion from this study is definitely that the rate of decline of your own kidney function following the start of dialysis treatment is much slower and lasts longer than we had ever realized. And I think this is a really important finding. This may be because we are using this standardized fluid assessment protocol, which allows people to focus on that kidney function. Of course, we were measuring it in this study. Many units don't measure this. I think this is now what I would call best demonstrated practice. What we found was that adding the Bio-Impedance didn't really make any difference to this, but as I've told you, that's simply because the clinical assessment was just as good as the Bio-Impedance. There was evidence that clinicians and patients agreed most of the time in their fluid assessments, which I think is encouraging. The other thing I would say is that in this trial, where we observed fairly good preservation of residual kidney function, actually dialysis-related symptoms were relatively low, fairly infrequent. For example, I'm talking things like cramps and dropping in blood pressure during the dialysis session. If you've got that residual kidney function, you need to take less fluid off, and that helps reduce the symptoms. And then finally, just to say a very important point, that we also, of course, are mandated to look for evidence of harm when you do a study. And I can report that there was no evidence of harm done in this study, and actually that the deaths and transplantation rates were exactly the same in both groups. So in completing my presentation, I just wanted to make some thank yous, because undertaking a trial of this size is no mean feat. And there are a number of bodies that really supported this. The management of the trial by the Keele University Clinical Trials Unit. We had a trial steering committee, which was chaired by Richard Fluck. We had a patient advisory group that David Coyle chaired, and David may say a few words about that in a minute. We had an independent data monitoring group to make sure that we were reporting the data correctly. And of course, we had significant funding for this study from the National Institute for Health Research. But most important of all, I want to thank all the patients and all the site teams. I obviously can't do that individually to everybody, but I'm extremely grateful for the wonderful efforts and supports by patients and their clinicians from these 34 sites across the country that made this trial possible. Many thanks for listening to me.
Thank you very much, Simon. We've got just the one question for yourself or David, and that's about GFR. At what point GFR dialysis would be considered?
So it depends a bit on the patient's symptoms and things, but I think a GFR of around 7, 8 is when people are usually starting dialysis treatment. In fact, in this particular study, we measured it properly as opposed to estimating it from the so-called eGFR. And actually, I can tell you that at the beginning of the study, the eGFR in both limbs of this study was 5. 5.2 to be precise. And interestingly, it tailed off fairly slowly over the 2 years. So even by 2 years of treatment, the eGFR average eGFR in the study was around about 2.5. So that's new knowledge. Actually, people thought that it tailed off more quickly. I'd like David to have the opportunity, if he can, because I think we've got a couple of minutes, Pete, just to say a little bit about the patient involvement in the study.
Yes, please do. We have got a couple of minutes. So, David, if you'd like to say a few words, go ahead.
Yes. So, hello again, everyone. So, the patient voice is very important in research, and a constant problem is trying to illustrate and demonstrate how the patient voice helps in research. So I'm just going to say 3 points about BISTRO. Firstly, the patient voice was represented right at the heart of this project. So myself, as a patient with lived experience, was on the core team. That meant I had access to every aspect of the study and could represent a patient point of view, which wasn't my point of view. It was my point of view and the PAG group's point of view. So I was backed up with a PAG group of patients from around the country, different ages, different backgrounds, which interestingly was a virtual group as well, which proved very useful when COVID hit. And the 3 examples of where working as a team, collaborating, patients can help. The first is when you're designing the study. So if you think about the profile of patients on this study, we're just starting dialysis. We can all remember that, those of us that have been through it. Our state of mind, we're worrying about things. It's a massive change, control in our life. So it's a very sensitive moment in our patient pathway. And what we were able to do is bring that to life for the people who were designing the study, so they could take that into account in what's called patient burden. So questionnaires are not too long, urine collections, blood samples, and it's important to take that into account because from the study point of view, this is a long trial and there's lots of data to collect. So unless you design it in a sensitive way, you won't keep the patients in the study. So in that design stage is very important. Recruiting patients to the study. So we were able to support the research nurses. So we all know when we go and see a doctor, we also quite like to talk to a patient as well. Patients talking to patients is very important. And whilst we didn't use that service very much, it was made available to the research nurses that if somebody was a bit unsure about the study, they could talk to one of the PAG group. So we made that available to them and raised the awareness about the study as well to help the recruitment. But the really important work was in the retention. As Simon said earlier, this was a very long study. delayed by COVID. So keeping participants in the study, very, very important. And so we did this in a number of ways. We had a whole series of personalised communications to participants. So we had little postcards welcoming them to the study. We had postcards at key points in the trial. We had a newsletter, which was a lot more than just, this is a study update. It had three aspects to it, because the newsletter was an absolute collaboration between the teams. So we had an update on the study. We did articles about people in the study so people could understand what's involved. And we had a kind of a welfare element, which was particularly important during that COVID period, of patients, talking to patients with tips of how to keep going. And communication, so the look and the feel, the plain English, all of that. So there are three examples of the work we did. And why was this study important to me? But anything that helps us prolong our kidney function has got to be a good thing. And I found this very interesting, that here was a trial where the expected outcome wasn't as expected, and I'd never come across something like that before. But the learning that we've got around how to manage target weights and liquid management, that's the big success story for me in this. Hope that helps.
David, thank you very much. We've got one more question before you both go, and it says, were other medical conditions considered, like diabetes, high blood pressure, etc.?
Certainly they were, because it's a very important aspect of what happens in dialysis patients. So we measured that at the start of the study in terms of what different conditions people had. And we also encourage clinicians to think about that when they were setting the target weight. And there will be some secondary analysis of the trial showing how that actually influenced those decisions. But I can tell you today that the trial was well balanced. In other words, the number of people with different conditions in both parts of the trial were identical. We can also tell you that we found that when we're talking about the rate at which kidney function is lost, that actually age was the most important predictor of the speed at which you lose kidney function on dialysis. And interestingly, the older you are, the slower that is. So that counterbalances what we thought would be the case, which would have been having lots of other conditions would mean you lost your kidney function more quickly. So it's quite an interesting observation, that, and we need to do some more work on understanding that data. But it seems to be that what you might think intuitively is that older people with more other conditions might lose their kidney function more quickly. It turns out that actually being a bit older is associated with better preservation of residual kidney function after dialysis.
I've got 2 more minutes, and I've just had another question come in. How is target weight decided?
So it's what I call a complex decision. And that's really important to understand. That is, it's not a single thing that tells you what that target weight should be. What you're trying to do is to assess what the right weight is, such that a patient is not got excessive fluid on board, but is not dehydrated. And some of those things can be done on regular questions, like, do you feel thirsty all the time? Have you got swelling? Those things can help you decide whether there's extra fluid or not enough fluid. But you've also got to remember that the weight is affected by how much a person eats, for example. So if they're eating well because they've started dialysis, they might put on weight, which is body weight, but not fluid weight. So that's why all those aspects of the measurements need to be taken into account. And the bio-impedance measurements didn't seem to really add to the clinical evaluation in that situation. But it is a complicated decision. And as I think we've also demonstrated very nicely in this trial, how a patient feels at different weights is also very important. And I'm sure that most people on dialysis who've experienced having excess fluid or not enough fluid on board will have started to recognize what that feels like. And I think that this study shows that that should be taken into account by doctors and nurses when they're setting the target weight.
Well, thank you very much. Very interesting study, Simon and David, for your time.